I think this should be working now. And
yes, I can see your full screen slides.
Oh, there's a problem though. The text. Oh, yeah, no, okay, that's fine. I put animations and I forgot.
Okay.
Okay.
Are you using PowerPoint Live?
Just PowerPoint.
Okay. Oh, and you're using a Mac. Okay, perfect.
Yeah.
Good morning, everyone.
Good morning.
Good morning.
So I presume we're going to go live at 7:30-ish.
Yeah, we'll do 7:31. We'll turn off the lobby and admit everybody. And then if you just give us literally 15 seconds to do that, you can take it away. You don't need a full minute.
Okay, that sounds good. So we'll start at 7:31. Amelie, are you ready to go?
Yes.
Perfect.
All right. So if we could just get your slides up on the starting slide, and then that way that's on the screen for when Dr. Stadnik introduces, and then we'll be all set.
Okay, sounds good. Just a last minute modification, just a second in
Sure, no problem.
you. So I think you should see it now and see myself too.
Okay, Andrew, I'm allowing everyone in from the lobby.
Okay, I'm admitting everybody. Dr. Stadnik, you're good to go.
So good morning, everyone. Welcome to Wednesday morning cardiology rounds. Today we have Dr. Amelie Paquin. She is one of our advanced echocardiography and women's cardiovascular health and clinical research fellows. Amelie completed her cardiology training at the University of Laval. She completed her master's in clinical epidemiology during her cardiology training. And she's currently working on her PhD while pursuing a fellowship with us in echocardiography and women's cardiovascular health. So we welcome her today as she talks about sex differences in valvular heart disease. Welcome, Amelie.
Thank you very much. Thank you for the introduction, and thank you for the invitation to present to you this morning about a topic that I'm very passionate about, which are sex differences in valvular heart disease. So the plan of my presentation will go this way. So I want to start first with setting some basis for sex and gender-based analysis, and we're going to discuss about some examples of how it impacts valvular heart disease. We're going to go also through some differences in the epidemiology, presentation, investigation, and in the interventions and outcomes, all with an eye looking into the valvular heart disease differences. And the idea of my talk is to have a quick glance of these differences in valvular heart disease going from bench to bedside. So I have no conflict of interest to disclose. So the objectives of my talk for today are, one, to better understand the importance of sex and gender in valvular heart disease from both a research and clinical perspectives, which is the why in the title of my presentation, and also to learn about different aspects of valvular heart disease that can be affected by sex or gender, the how. And lastly, I would like to convince you by the end of my talk that the study of sex differences in cardiology is fascinating. So first of all, before we go, some ground rules. For a very long time, the words gender and sex have been used interchangeably, but lately in the recent years, it's been defined that these terms refer to two different aspects. With sex, which is what comes to our mind first, the biological attributes that are specific to the sex chromosome, so either bearing two X chromosomes or bearing an X and a Y chromosomes. And sex will impact physical characteristics, DNA, chromosomes, gene expression, hormones, and different anatomy as well. Whereas the word gender should be used more so regarding the social and behaviors attributed to either a feminine or a masculine gender. For example, the feminine role of being a mother or of having the main responsibility for children. But we know nowadays that the spectrum of gender can vary a lot from one person to the other. It also includes different lifestyle habits and the identity established by society. Just to give you a quick example of how gender can have a significant impact, and to me this is the most striking study in the potential impact of gender. It's not related to valvular heart disease, but I still thought it was worth mentioning. This is a beautiful study that was done by Louise Pilote and her team at McGill, where they evaluated young patients aged 18 to 55 years old who suffered from an acute coronary syndrome, and they evaluated the risk of ACS recurrence at 1 year. And what they found is that when they compared sexes, men to women, there was no significant difference in the risk of recurrent event at 1 year. However, when they compared gender score using the different parameters that I've put in the box here, they found out that feminine characteristics were associated with more than twice the risk of a recurrent ACS event at 1 year, when compared to someone with masculine characteristics or with someone who has more of a mix of both feminine and masculine characteristics. So this is not benign, and I think this definitely needs to be studied more. With regard to sex-based analysis, the sex-based analysis will involve different steps in the sex differentiation, going from the chromosomes. So as I mentioned before, XX versus XY. Then wearing that DNA will lead to different gene expression and then different hormonal production. As you already know, women will produce estrogen and progesterone, whereas men will produce testosterone and androgens, and this will lead to different physical characteristics. What's very interesting to know is that by the end of the first trimester, a masculine fetus, a male fetus, will start producing testosterone, and this surge in testosterone hormone is what is going to cause epigenetic modification with irreversible altered gene expression that will later lead to the formation of the male gonads and of the male body. An example of how gene expression can have a significant impact in valvular heart disease is in aortic stenosis. More and more there are studies evaluating the different gene expression, trying to find what are the different pathways that can be involved in the different pathophysiology of AS. And there's this very interesting study where they compared the harvested aortic valves of 18 males to 18 females who underwent aortic valve replacement for aortic stenosis. And they compared the gene expression in the very diseased tissue to tissue that seemed more healthy within the aortic valve, and they found 149 genes that were expressed differently between males and females. As you can see in the table here, some of these genes are associated with the immune system, some of these genes with inflammatory response, collagen production. However, from these kind of studies, we cannot attribute any causal impact because we don't know if this gene expression is associated with a mechanism that follow, but it's definitely hypothesis generating, and it's a significant objective difference that we can measure. We all know that the estrogen has significant cardiovascular effects. The estrogen is known to be a strong vasodilator. It also decreases endothelial dysfunction. It has antioxidant properties as well as anti-inflammatory properties. So we can imagine how this can influence valvular heart disease. However, very little is known regarding the role of testosterone in cardiovascular system. Some studies suggest that it also provides vasodilation. It may alter the progression of atherosclerosis, but results are conflicting. Similarly, results seem to be conflicting regarding its impact on inflammation, and a potential protective effect regarding insulin sensitivity and lipid homeostasis, but again with conflicting results suggesting that probably many different pathways are involved in these systems. Testosterone is also associated with increased salt and water retention, erythrocytosis, and increased platelet aggregability. So if we look more closely into how these sex differences can impact the pathophysiology of valvular heart disease, one of the diseases that has the most studied published regarding the sex differences is definitely aortic stenosis, where we all know that for a similar degree of severity, women will have more fibrotic tissue within their aortic valve leaflets compared to men who will have more calcification. If we look a little bit more closely in this study where they compared 24 patients undergoing aortic valve replacement, we can see that men had more calcification as seen on the cardiac CT calcium score, but also when we use a hematoxylin eosin staining, we can see that there are more calcium nodules within the aortic valve tissue, as shown by the purple acellular nodules, the red arrows, whereas in women we will find more fibrosis pointed by the black arrows in the pink acellular areas. As well, if we use the Masson trichome staining, we'll see again more calcium nodules and more myofibroblasts, calcium nodules being the purple nodules and the myofibroblasts shown by the red fibers, whereas women will have dense connective tissue and loose connective tissue shown by the dark and the light blue color in the tissue. And similarly, if we put a polarized light with a picrocereus red staining, we'll see more dense collagen fibers within the valvular tissue of women with aortic stenosis. So now seeing these differences between both sex, we need to go back and understand what are the mechanisms that lead to the creation of these differences. There's still a lot to know, but I thought this study here was interesting, where they compared again the valvular tissue, the aortic valve interstitial cells of men and women, they were able to simulate with interferon alpha and interferon alpha potentiated by liposaccharide, and they were able to see that male aortic valve interstitial cells developed higher osteogenic response, shown by the increase in the bone morphogenic protein 2 as compared to women. Women's aortic valve interstitial cells, and similarly in the male cells, the interferon alpha potentiated by liposaccharide also provided an increase in the BSP2 production, which is associated with osteoblastic differentiation. So possibly the inflammatory response in male aortic valve interstitial cells could differ from female in the fact that this inflammatory response might trigger the bone formation in a way that is different with female aortic valves. What's also interesting to know and to see is that if we compare the cell types that we find in aortic valve stenosis patients, this study here harvested 28 male valves and 28 female valves from surgery, and we can find that in men there was an overrepresentation of immune cells, possibly related to more of an inflammatory response. An immune response, whereas in women there was an overrepresentation of mesenchymal cells associated with fibrotic tissue formation and collagen production. Another interesting difference that we see in both sexes is that the LV response to increased afterload in aortic stenosis seems to differ between male and females. This response is conflicting in some studies, but most studies suggest that there's either concentric hypertrophy or concentric remodeling that would be more frequent in women compared to men. This is a very recent study that was in press, that is still in press in the JACC Cardiovascular Imaging from Ito et al., where they compared 927 patients with severe AS, and they went back looking at their echoes from the 7 previous years until they reached severe aortic stenosis. On the left side, we have women. On the right side, we have men. And we can see in the green, in the purple rectangles, we can see that there's a higher proportion of women developing concentric hypertrophy until they reach time 0, which corresponds to severe aortic stenosis. Another difference also is that there seems to be a higher extracellular volume fraction in the LV of women compared to men by MRI, whereas men will have more of a focal fibrotic pattern with increased late gadolinium enhancement. And in this study by Lionel Taste et al., they also showed that there were more elevated LV filling pressures, which corresponds to possibly to worse diastolic function. If we again take back this study that's still in press, 927 patients with severe AS, they had similar findings of having higher filling pressures in women, as you can see here in terms of proportion of prevalence between both sexes. And also if we look at the continuous data from the E to E prime ratio, there was a significant difference with higher ratios in women as expressed by the red line compared to the green line, which represents men. Likewise, on the other side, there are some studies that suggest that men tend to have a lower systolic function, a lower EF compared to women in response to increased afterload. The same study showed lower LVEF with an average of 56.7 at the time of severe AS compared to 61.6 in women at the time of severe AS. And also some results with looking at MRI where they compared 133 men to 41 women, where we can see that the LVEF was slightly lower compared to women. However, there are also 3 other studies that did not show significant differences between in LVEF between sexes. So this is still subject of debate. But knowing that there is more late gadolinium enhancement, more focal fibrosis, and also more CAD affecting patients with aortic stenosis who are men, this would make sense also that their systolic function would tend to be lower in that context. If we look at the specific hormonal impact on LV remodeling, here is I thought it was interesting to show you that within the cardiomyocyte, the sex hormones have a very different pathway of affect LV remodeling. So if we look at the female pathway, we can see that the estrogen has an impact by linking the estrogen beta receptor and inhibiting the cascade following stimulation of this receptor by angiotensin 2 or endothelin 1. The estrogen also has an impact on the estrogen receptor beta and alpha within the mitochondria, leading to decreased production of reactive oxygen species and also providing increased ATP synthesis. And the estrogen will also prevent the production of reactive oxygen species in a pathway, either using the G protein estrogen receptor or directly through the SIRT1 production. And downhill, these pathways, you can see that they are involved with gene expression, leading to hypertrophy and contraction. When we compare to When we compare to male impact on LV remodeling, we can see that the androgen receptor are located at different places in these cascades, and there are androgen receptor really located close to the DNA, and that will directly have an impact on gene expression, leading to contraction, and it will also have an impact in the mTOR pathway that leads to hypertrophy induction and hypertrophic gene expression. Similarly, if we look at the level of the fibroblasts for extracellular matrix production, you can see that the estrogen receptor alpha and beta have different impact in these pathways, as well as the androgen receptor that is inside the cell and that will act after stimulation of the receptor for angiotensin 2 and endothelin 1 that will inhibit its stimulation to the TGF beta 1 process. So you can imagine, looking at all these different mechanisms, how they differ between both sexes, you can imagine all the different impacts that this can have when we add on top of that a valvular heart disease. The other thing that makes it even more complex is that we know that with menopause, estrogen production very drastically declines. So how are these pathways modified by the decrement in estrogen receptor production and by the decrement of estrogen stimulation of these receptors, and also with in men with the andropause, so with the slower decline in androgen production, how this can have an impact at these other levels. An interesting study that I found was, and that is very frequently quoted, is that they did this study among mice models, and they did transverse aortic constriction compared to sham procedure to simulate aortic stenosis or to simulate an increase in the afterload. And they compared female mice with those who had ovariectomy, so meaning those female mice that were not producing estrogen, to mice who had intact gonads, so that who could produce estrogen. And it's interesting to notice that the group that had ovariectomy and transverse aortic constriction, so increased afterload without estrogen production, this group showed a higher LV mass, a higher cross-sectional area of myocyte, and a higher interstitial collagen volume fraction when compared to the other models, suggesting that the absence of estrogen in this group led to worse LV remodeling in response to increased afterload. Similarly, when they gave estrogen 3 days before performing the transverse aortic constriction, this effect seemed to be avoided by giving estrogen to these models, as we can see in the second column here, that shows that there was no increase in remodeling, similar to what we could see with the previous models, or what we could see when we compare to the ovariectomy, total or aortic constriction, and no additional estrogen. No, sorry, this is chymase. But when we compare to the ovariectomy and total aortic constriction, this is the first bar. When we compare to the first bar, we can see that this effect was protected by giving estrogen to these models, meaning that likely in women, the estrogen does have a protective impact in the development of remodeling, and possibly could explain why at the surge of menopause, when there's a decline in estrogen production, this protective effect is no longer present. So now let's have a look at the epidemiology of valvular heart disease. Calcific aortic valve disease, we know that it tends to affect more men compared to women. However, this prevalence is reversed when we come to more elderly patients above the age of 80, where it seems to affect more women, possibly related to better life expectancy. Bicuspid aortic valve affects more male than female in a 3-to-1 ratio. And degenerative mitral valve disease seems to affect more frequently women compared to men. There's also more women affected by arrhythmogenic mitral valve prolapse, and there's also more rheumatic mitral regurgitation in women compared to men. If we look at the kind of mitral valve prolapse, there's this nice cohort study that accumulated data on 8,000 patients from the Mayo Clinic by Serrano et al. And they showed that women who had mitral valve prolapse were less likely to have flail of their mitral valve prolapse, had thicker valve leaflets, and had more frequently bileaflet and interior leaflet prolapse when compared to men who had more frequently bileaflet or posterior valve prolapse. Surprisingly, if we look at ischemic mitral regurgitation, knowing that males suffer more from ischemic cardiomyopathy, we would think that it would have be affected more by ischemic mitral regurg, but in fact, it seems to affect more women than men. If we look at this cohort from the Cadillac cohort that included about 2,000 patients with acute myocardial infarction, we can see that male sex accounted for less than half of the patients who were affected by moderate to severe mitral regurgitation. And similarly, in the Valiant cohort that studied valsartan in patients with heart failure or systolic dysfunction post-MI, even though female accounted for only 30% of the whole study group, their presence was 46% among the patients who had moderate to severe mitral regurgitation. Then if we look at the tricuspid regurgitation seems to affect more female than male again. In this study from the Olmsted County, looking at patients with at least moderate tricuspid regurgitation, if we adjust for age, there seems to be a higher rate of at least moderate tricuspid regurgitation in female compared to male. The underlying etiology also differs between sexes, with women being more frequently affected by TR secondary to left valvular heart disease, or secondary to pulmonary hypertension, or isolated, whereas men will tend to have more frequently TR secondary to left systolic dysfunction. Now let's look at some of these differences in the diagnosis and investigation of aortic stenosis. Of aortic stenosis, yes. So we know that at time of presentation, especially at time of presentation for surgery, there are some differences in how these patients present. So women tend to be older, more frail, more symptomatic. They tend to have more advanced aortic valve disease in most of the studies. They have more concentric remodeling or hypertrophy, as we've mentioned before, and they also have more diastolic dysfunction and more pulmonary hypertension, whereas men will tend to be younger, will tend to have more comorbidities, more CAD as well, and will have more frequently systolic dysfunction. One of the challenges that we have in aortic stenosis severity assessment is the presence of discordant gradings. Discordant gradings meaning that we have an aortic valve area that suggests severe aortic stenosis, but the gradients do not reach the severe threshold, so the mean gradients remain below 40 millimeters of mercury. Discordant gradings is thought to affect about a quarter of patients with severe aortic stenosis, and we know that these patients are more frequently elderly women with concentric remodeling and reduced systolic or diastolic dysfunction. And we know that the stroke volume index also seems to have a significant impact in the prevalence of discordant gradings, making the diagnosis of severe aortic stenosis more difficult in these patients. The use of CT is another imaging tool that is now more and more being used in the diagnosis, or at least in the severity assessment of aortic stenosis. And we know that because there are more calcification on men aortic valves in aortic stenosis, well, it's logical that they would also have a higher calcium score when we measure the calcification burden on cardiac CT. So here in this study to which Dr. Messica Zitoun participated, we can see that when we compare the tertiles of calcium score between male and female, so men in white, women in dark, we can see that the aortic valve area for comparable calcium score was lower in women compared to men for all three categories. And when we look at the peak aortic jet velocity, a similar pattern of a worse peak aortic jet velocity in women compared to men was found among the three tertiles as well. What's interesting with the use of CT is that it was also evaluated in patients with aortic stenosis and discordant gradings. And we can see that there was a significant difference when we compared patients with severe AS defined by an AVA below 0.6 centimeters square per meter square, but with low gradient, mean gradient below 40, between this and what is considered to be true moderate aortic stenosis with an AVA above 0.6 centimeters square per meter square and a low mean gradient. This discriminant use of the CT could also be found in men. But knowing that more women will fall in these categories, it's a very interesting tool, especially for women, which led to the inclusion of sex-specific criteria for calcium score into the guidelines for aortic stenosis severity assessment published by the American Society of Echocardiography. So we can see here that severe aortic stenosis is more likely when men have an Agatston unit score above 2,000 and in women above 1,200. It's important to keep in mind that these are likelihood, so probability of severe AS. When we look back again at the previous slide, we can see that some patients who are presumed to have severe aortic stenosis still fall below these thresholds. In men as well. So this is not a tool that can be easily used to rule out aortic stenosis, but can help rule it in. Now, if we have a look at the presentation investigation of mitral regurgitation, if we look at the clinical presentation at time of surgery, women tend to be older, men tend to be younger. More specifically, in primary mitral regurgitation, women tend to have more symptoms of heart failure, more comorbidities, more advanced ventricular disease, and more atrial fibrillation and pulmonary hypertension. When we look at secondary mitral regurg, women tend to have more symptoms and worse quality of life, while men tend to have more advanced ventricular disease and more severe mitral regurgitation. There are also some challenges in the assessment of mitral regurgitation severity specific to sex. So in this study from the Cardiothoracic Surgical Trials Network, they compared the severity of mitral regurgitation measured by effective regurgitant orifice area, which was significantly smaller in women compared to men. However, when we indexed this regurgitant orifice area to the left ventricular and diastolic volume, it suggested that, in fact, the MR severity was possibly higher in women compared to men. And this makes sense that if you have a smaller left ventricular cavity, that the volume of the regurgitation would also be smaller if you take absolute measurements. But I think this is one of the rare studies that evaluated these differences by indexing the severity gradings of mitral regurgitation. Similarly, if we look at the consequences of mitral regurgitation severity on the left ventricle, in this study, again, the same study from the Mayo Clinic with 8,000 patients with mitral valve prolapse, we can see, looking at the LV and systolic diameter, that it was lower in female compared to male, both in the moderate and severe mitral regurgitation groups. However, if we index this value to the body surface area, it was actually the opposite, suggesting that women had more severe LV dilatation compared to men, both in the moderate and severe regurgitation group. And similar findings were found when we looked at the end diastolic diameter and at the index end diastolic diameter, which ended up being higher in female compared to men. Yet, despite these studies suggesting a need for index values, which also makes a lot of logical sense, there are absolutely no index values for body size when we look at the criteria for assessment of mitral regurgitation severity by echocardiography. I also took the time to look at all the references that led to the inclusion of these numbers into the guidelines, and among all these references, there were absolutely no study that evaluated sex-specific threshold, and they only mentioned the proportion of women that were included in their studies, and more often there was less female than male. Similarly, if we look at the guidelines for mitral valve intervention, again, absolutely no values are indexed for body size or LV size. Now looking at the sex differences in the interventions and outcomes in valvular heart disease, some example regarding aortic stenosis. There seems to be a gap between men and women looking into the referral rate for aortic valve intervention. In this study that accumulated all patients who had severe AS on a transthoracic echo between 2000 and 2017. In this cohort, women had similar AS severity compared to men, comparable mean gradient as well, and possibly better LVEF in women compared to men. Yet, the rate of aortic valve replacement and the time to aortic valve replacement were much worse in women compared to men, as we can see also in this graph regarding the cumulative incidence of aortic valve replacement. And this gap remains statistically significant even after a propensity score matching between patients with less AVR and more time to AVR in women. Similar findings were found in this paper by Marianne Clavel et al. At the Quebec and Heart Institute, looking at 3,600 patients who had at least mild to moderate aortic stenosis and preserved EF. And what they could see is that in the whole cohort, there was less aortic valve replacement occurring in women compared to men. And this gap seemed to be more important in patients who had discordant, low gradient aortic stenosis. So the same group that we mentioned before, with an AVA suggesting severe AS, but a mean gradient below 40. And we can see that the rate of AVR was lower in women compared to men. And this could possibly explain why also worse survival was observed in women compared to men in this specific subgroup. However, causality can only be hypothesized, it cannot be confirmed. But there is still something here about why are these women not being referred and why are they dying more of this disease. Another idea that is thought to be associated to this gap in rate of referral is the possibility that our assessment as physicians, as cardiologists, might be biased by the sex of the patient. This was suggested by a study published in 2007 where they look at 128 insurance claims in the US of patients at least 65 years old with a first diagnosis of aortic valve disease. And what they demonstrated is that women were less likely to be referred to a specialist when compared to men. And especially looking at patients above the age of 80, women were less likely to be referred for an echocardiogram. And in both age group, women were less likely to be referred for an aortic valve replacement. Lots of potential for confounders here because this is only looking at insurance claims. We don't know the etiology. Again, not all of these patients had an echo that was done, but still there is no explanation as to why more men would be referred to a specialist if you put an aortic valve disease diagnosis in the insurance claim of this patient. So just some food for thought for us to introspect. To do some introspection regarding that. If we look at the outcomes post-surgical AVR, most studies suggest an increase in hospital mortality in women, and this seems to be constant even though the mortality decreases. There still seems to be a gap with women having more in hospital mortality. However, the results regarding long-term mortality are conflicting, with possibly more equal survival in the latest studies. However, there is always an increased risk of vascular and bleeding complications that comes out in most of the studies regarding outcomes post-AVR. If we look at some local data, I found this very interesting paper by my colleague Amy Johnston, who looked at the clinical registry data from Core Health Ontario from 2008 to 2016. This cohort accumulated data from 72,000 patients, 24% female, and the survival probability was similar between sexes when comparing patients with simple aortic valve replacement or when comparing patients with aortic valve replacement, either with mitral valve replacement or with CABG combined. These data were adjusted for underlying comorbidities, LVEF. However, we do not know what the severity of the aortic stenosis was at the time of surgery. But still, in this large database, it's reassuring, and coming from Ontarian data, this information is reassuring. If we look at the transcatheter aortic valve interventions, we know that the women tend to have actually a better 1 year and long-term survival compared to men. However, they do suffer from more strokes, more bleeding, vascular complications. And in this meta-analysis where they combine 8 TAVR registries for the 8,000 patients, there did not seem to be any significant difference in hospital mortality. We need to keep in mind that these meta-analyses combine observational data, so male and female groups were not perfectly balanced for potential confounders. But again, looking at the large number of patients, this data is reassuring, but there's still something that we need to work on regarding stroke and bleeding vascular complications incidence. If we look at some more recent data, I found this paper looking at the Vision's clinical database, 44,000 patients who underwent third generation TAVR, which means SAPIEN 3 or Evolut R, between 2018 and 2020. And in this cohort, at 1 year, in-hospital mortality seemed to be higher in women, even when adjusting for potential confounders in 2 different models. There is still something that we need to work on in terms of how women evolve inside the hospital, possibly associated to this increased risk in stroke and vascular complications and bleeding complications. And these complications were also found to be increased in this more recent cohort in women. If we look at the outcomes of mitral regurgitation, again, looking at the cohort of mitral valve prolapse, women had less often cardiac valve surgery than men, even after adjusting for severity of mitral regurgitation, for diastolic LV diameter, and for left atrial diameter. Women with severe mitral regurgitation also had worse survival, and it is thought to be possibly related to this discrepancy in cardiac valve surgery referral. If you look at the degenerative mitral regurgitation at large, these tables might look familiar to you. Paper written by Vincent Chan et al., where they compared 277 female patients to 735 male patients who underwent mitral valve repair. And what was interesting is that the long-term mortality did not differ between sexes. However, female sex was associated with less reduction in LV size after the surgery, so less favorable remodeling post-mitral valve repair. It's also interesting to notice that it did not reach statistical significance. However, there was a strong trend for larger LV and systolic measurement when indexed by body size. So a possible explanation for the unfavorable remodeling post-surgery. If we look at organic mitral regurgitation in this cohort that combined patients who had mitral valve surgery at the Mayo Clinic between 1990 and 2000, compared 447 male to 217 female, again, we can see that the women tended to have larger LV diameters when indexed to body size. There were, again, no significant difference in terms of long-term mortality. However, women seem to be at higher risk of developing heart failure at follow-up, and this risk remains statistically significant even after adjusting for AFib, for repair performance, for higher risk, and for concomitant CABG and coronary artery disease, as well as age and Charlson Index score. And some other data coming again from the Ontario registry, just to look at something a little bit more local. If we look at the survival probability in men and women undergoing mitral valve repair or mitral valve replacement, there seemed to be a better survival with repair in both men and women. And however, when we compare between sexes, men and women seem to have a similar survival when they underwent mitral valve replacement. However, survival seemed to be worse in women who underwent a mitral valve repair. If we look back at the cardiothoracic surgical trials network that evaluated ischemic mitral regurgitation outcomes, this is the study where I showed you that the effective orifice area indexed to the LV and diastolic volume ratio was suggested worse mitral regurgitation in women. In this study, women also had worse 2-year mortality, higher 2-year risk of MACE, worse 2-year quality of life, and worse 2-year functional status when compared to men, with similar LV remodeling at 2 years. So we cannot make a causal link between the worse MR and these outcomes, but this appears logical and would deserve better attention in the future. And to finish, just a few words about percutaneous mitral valve repair. So this is a relatively new technology, so we don't have a lot of sex-specific data yet. But if we look at the German TRAMI registry that compares 327 women to 501 men who underwent Mitraclip between 2010 and 2013, mortality seemed to be similar between both groups. And I also found a recent meta-analysis of all registries of Mitraclip. In these registries, women were again older, but had lower prevalence of comorbidities when compared to men. Again, women had higher risk of bleeding and stroke following Mitraclip. There was no difference in the 1-year mortality risk or risk for hospitalization for heart failure. And when they did a meta-analysis of the adjusted risks for long-term mortality in these trials, there was possibly a lower incidence of mortality in women. But again, we need to keep in mind that we are combining observational data, whereas the characteristic of male and female are not necessarily well balanced between groups. And again, doing a meta-analysis of adjusted risks from different studies, this is not perfectly kosher with regards to statistics. So perhaps a good signal, but we're not sure yet. And the future will tell us for sure. So just to summarize a few sex-specific considerations for valvular intervention, we've named some of them, but I thought it was worth discussing of some others that I did not have time to show you some studies or that are not necessarily studied concretely. So we know that women and men differ in body and heart size. So we've mentioned it with regards to evaluation of severity of valve disease on LV size, but it also has technical impacts in terms of procedure. We know that women have smaller LVOT, smaller aortic root, which increase their risk of patient-prosthesis mismatch and can lead to some technical consideration for surgeries. And women have breasts, so when they have very large breasts, we know that this increases the risk of postoperative complication, more specifically wound dehiscence and wound infection. Also, when thinking about sex differences, we need to consider vessel size. So this likely explains a significant proportion of why women have higher bleeding and vascular risk compared to men, knowing that our catheters for transcatheter intervention remain quite large. But hopefully this will improve in the future as technology improves as well. Also, bleeding and embolic risk in women, we see a similar risk also in women with atrial fibrillation compared to men. So there's possibly an intrinsic risk to women as well, possibly independent from their body size. We don't know yet why this risk is more elevated. One of the hypotheses is that we know that heparin clears more slowly in women compared to men, so possibly increases the risk of bleeding from that perspective. We've discussed a lot about severity assessment of valvular heart disease, how it can differ between men and women, and that we need to study more sex-specific thresholds. The assessment of ventricular consequences similarly. And also to mention frailty, which we know frailty affects more women compared to men, but the impact of frailty in aortic valve interventions, more specifically, especially with the era of transcatheter interventions, the sex-specific impact of frailty will have to be better studied, and then I can talk to you a little bit more about frailty after the talk if we have some time. And then to finish, we also know that the pharmacological response and tolerance to guideline-directed medical therapy differs between both sexes, which can also have an impact on the outcomes. So I know you're all thinking now, but Amelia, what about gender? So I haven't forgotten gender, but there's not a lot of studies regarding valvular heart disease, unfortunately. But we know gender involves many different factors. This is the gender score that Ms. Pilot used in her study, and there are many factors that can influence the gender, including race, culture, politics, history. And there's this new term provided by the Canadian government, which is SGBA+, Sex and Gender-Based Analysis Plus, that promotes the intersectionality of all these factors and how they all interact together and impact the expression of sex and gender, and can impact health in the end. So you can imagine how complex it is to evaluate in research, but you can also imagine all these different criteria, how they can have an impact on lifestyle habits, which are cardiovascular risk factors, how they can impact access to care, treatment compliance, exposure to environmental factors, etc. Just a quick example, we know that women tend to have more of a sedentary behavior, and just a few examples of how a sedentary behavior of being a mother, caring for children, not being exposed to sport the same way men are at younger age, how it can impact the development of cardiometabolic comorbidities, having an impact on operative risk, on the consequences of valvular heart disease, or on comorbidities to valvular heart disease, how it can lead to obesity, impact clinical evaluation. We know that functional capacity in sedentary women is more difficult to assess if they are not walking ever and then they become slightly shorter breath when they walk. Is it because they're deconditioned, or is it because of their valvular heart disease? And it can also influence rehabilitation success and stress and depressive symptoms that also has an interaction with all these bubbles here. So to conclude, we've gone through the spectrum of from science to epidemiology, presentation, investigation, and intervention outcomes with a lens specific to valvular heart disease, and you can understand how sex and gender are fundamentally and frequently interrelated, especially in the field of valvular heart disease, but also in other fields of cardiology and medicine. Some key messages: there's a potential gap in referral for valvular intervention in women. There's a trend for worse in-hospital mortality as well following intervention in women, more strokes, bleeding, and vascular complications. There's a need for sex-specific, up-to-date data with the ongoing progress in intervention and treatment for valvular heart disease. Some of the studies that I've presented to you already date 10 and 15 years, so we need more recent data. There's a need for reevaluation of the severity parameters and thresholds for intervention with sex-specific data. We need a better understanding of the impact of gender in valvular heart disease, and we need user-friendly tools to evaluate gender and interpret such data as well. And we need a better understanding of the sex-specific pathophysiological pathways that are involved in valvular heart disease, which will also help us develop perhaps eventually pharmacological treatment. So I hope I was able to provide you with a better understanding of the importance of sex and gender, that you learned about different aspects of valvular heart disease that are affected by sex and or gender. And most of all, I hope that I convinced you that the study of sex differences in cardiology is simply fascinating. So just a few special thanks to Dr. Thais Coutinho, who's my co-director and fellowship supervisor, and to the members of the Women's Heart Health Clinic who've been so welcoming, especially Nazli Paras, with who I work with in the clinic, and who shares a similar interest for research and for education. And I'd like to welcome any question, and I'm leaving a few reading suggestions for if you have more interest. Thank you.
Thank you, Amelie, for that comprehensive review. If you have a question, please raise your hand and we'll unmute your microphone. Dr. Coutinho has placed a comment in the chat board. I'm just going to kind of summarize it. But she's asking a question regarding sex differences in LV remodeling in response to increased afterload from aortic stenosis. And she's wondering if the remodeling observed in women in AS may be impacted by estrogen removal. And do you know if the sex differences in LV remodeling in AS are also present in younger patients with bicuspid aortic valves, i.e. those who may be premenopausal?
That's an excellent question. In my literature review, I unfortunately did not come across LV remodeling studies that included younger patients. We know that bicuspid aortic valve affects more men than women. So to look further into the LV remodeling at younger ages, we lower the N very much to study that. But it's an excellent question, and it would be interesting to compare for similar severity of disease, while also adjusting for the comorbidities that also come with age, how the LV remodeling differ between the age group. I'll look into this more specifically, and I think it could be an interesting study if some data is available regarding that.
And then a question from Dr. Burwash. How would you recommend correcting LV size for women? Would you use body surface area, height? I think he's trying to say height to 2.7 for decision making. What do you think is the optimal way to, index, I suppose?
I think that's an excellent question. My first response would be to index is already a good start. And then we have some index measurement in the chamber quantification recommendations. However, we do not know how these thresholds for quantification of LV dilatation affect prognosis. So these specific sizes, especially regarding mitral regurgitation, have been determined to have a prognostic impact in after surgery. So we would need to evaluate these thresholds more closely. However, in aortic regurgitation, there are some index sizes that are starting to be included. I have it here. And we can see that they included LV and systolic diameter indexed by body surface area. And there was a study that showed that this was associated with worse outcome when we went above this threshold. However, there's also a suggestion that perhaps these thresholds are not severe enough. There's perhaps worse outcomes when we're in the range of 20 to 25 millimeter per meter square. But this needs to be further studied.
And then a question from Dr. Kwan Chan. Nice talk, Amelie. In your review, women with aortic stenosis have less valve calcification and yet more osteoblasts. Why this paradox?
More osteoblasts?
Yeah, I can't recall your slide, but that was his interpretation, that there was more osteoblasts in women, but less calcification.
I'm going to try to go back. I'm not sure. Not sure if this is here. Here it was mainly about the impact of estrogen, and then when we look at histology, there was more calcium nodules and more connective tissue in female valves, and then there was more osteogenic response and osteoblastic differentiation in male aortic valve interstitial cells compared to females. I'm not sure if he's referring to the fact that women are also known to have more mitral annular calcification, which seems paradoxical because in that context, they do tend to have more severe calcification and more calcium accumulation at the level of the mitral annulus. We don't quite understand this process very well. It seems to be related to the increased stress response on the mitral valve, also related with inflammatory markers and with osteoporosis. But what's interesting to know is that even though the prevalence seems to be different, possibly the underlying physiological mechanism might be similar. because there was one very interesting study that I didn't have the time to talk about, where they looked in the MESA cohort and they compared bone mineral density, so sort of osteoporosis severity, to the incidence and progression of mitral annular calcification, and the relationship between both was quite similar between men and women, suggesting that perhaps the pathophysiological process is similar, but it's more the prevalence of osteoporosis that differs between sexes. And we know that osteoporosis can be tend to occur at the fall of the sex hormones, which is when estrogen decreases, when testosterone decreases, and you see that there's an age gap between both. So is this age gap also explaining why women have a different prevalence of mitral annular calcification? That's another question that we need to study more.
And perhaps along the same lines, a question from Dr. Beanlands. He's commenting again about this difference in calcification and fibrosis in aortic stenosis development. Do you think that this difference between male and female sexes changes the rate of progression of AS? And should we be following patients at different intervals based on their sex, if we're trying to grade, assess the rate of progression of the aortic stenosis?
So the data looking at sex-specific progression is conflicting. There is some data suggesting faster progression in women. There is also some data suggesting faster progression in men. What I can tell you is that men have more calcification burden in their aortic valve, and we know that the calcification burden and the aortic calcium score on CT are both strongly correlated with the speed of progression of AS. So it would make sense that men who have more calcification are at higher risk of faster progression. However, the current data cannot support or cannot support faster or more closer follow-up in men compared to women. The other thing is it's important also to consider other comorbidities that can affect AS progression. For my master's, we worked on evaluating the impact of myocardial infarction on aortic stenosis progression, thinking that the inflammatory surge related to myocardial infarction that we know has sort of a systemic impact also, not necessarily only local at the level of the myocardium, thinking that it could also have an impact on AS progression. It was a very small sample size, but we were able to demonstrate possibly faster progression of AS in men, and knowing that men are more affected by CAD, more affected by myocardial infarction, this is also something that can be confounding in these studies, and that could affect disease progression.
Excellent. Well, that takes us to the end of the hour. That was a great comprehensive overview, Amelie. Thank you very much. I think everybody really enjoyed that, and there's been a lot of good discussion around the topic. Best of luck with your research in the next year.